demyelination next. Okay. Then you know that the process of myelination starts inside the uterus, and the axons are covered by myelin, and this myelin is a protein lipid complex. This will start in the third trimester and continue after birth and is completed by the age of 2 years. Usually it is completed by the age of 2 years, but it may be delayed more than 2 years. Then being a lipid protein complex, this myelin will appear of bright signal in the T1 and dark signal in the T2 weighted images. Initially, the white matter before myelination contains water, and this water will appear of low signal in the T1 and high signal in the T2. Then by the start of myelination, then you got increased signal in the myelinated areas in the T1 weighted images and decrease in the T2 weighted images. There is a standard dates for this myelination, and also standard sites which is myelinated first. For example, the thalamus is one of the known areas that is myelinated at birth. And if you have an MRI of a newborn, then you will see a high signal intensity in the thalamus, which represents the myelinated area in this particular site. Then myelination continue by the posterior limb of the internal capsule, optic radiation, anterior limb, and the parietal lobes. Of course, many, or let us say, I am personally, I cannot remember the date of myelination of every part of the brain, but there is a chart which helps you to remember or to realize if this myelination is normal or not. And this chart is in my desk. Then if I have confronted by a case of this, either I go to the internet or I go to the chart to see if this myelination is normal or not. Then by the age of 6 months, you may got myelination of the brainstem and the myelination of the internal capsule and the myelination of the parietal white matter. And this is the chart by the full-term baby will have myelination of the medulla, the posterior part of the midbrain, the posterior limb of the internal capsule, the anterolateral aspect of the thalamus, and the deep central semi-oval. Then by the age of 3 months, you got the bones, you got the cerebellar folia, the ventral aspect of the brain stem, the optic radiation, occipital cortical U fibers, the splenium of the corpus callosum, and the anterior limb of the internal capsule. By the age of 8 months, and you got almost myelination of most of the white matter. And by the age of 2 years, you got full myelination of the white matter. White matter disorders are many, as you know. We have the primary white matter lesions, which are known as leukodystrophy or dysmyelinating diseases. The acquired white matter disorders. These leukodystrophies include a very long list of diseases. The acquired white matter disorders will also show in the second part of this lecture. Then you got disorders of both the white matter and the gray matter, and you got basal ganglia disorders like Huntington disease, Farr syndrome, and Wilson disease. These disorders will include Leigh's disease and Millas syndrome. Then what is the leukodystrophy? Leukodystrophy means that there is abnormal myelination or pathological myelination of the axons of the nerve fibers. This is the usual myelination, but here you can see many defects in the myelinating process. And the cause is known in some of these disorders and is related to particular enzyme deficiency. But sometimes the cause is unknown, and the features on imaging are more or less pathognomonic to this disease. What is important for all of you is that leukodystrophies are rare. All the items under this title are rare, and they almost share common clinical presentations. And you know, each of these may present in infancy or early childhood, may have a juvenile onset, and may have an adult onset, of course. There is hyperirritability and hypersensitivity. There is mental retardation, epileptic seizures, and optic and auditory degeneration. The course in the children is very rapid, and the mortality is high, while that of the adult onset are a little bit have a benign course. The first of these and the most famous of these leukodystrophies is known as metachromatic leukodystrophy, and it has the three types of onset. And the cause is deficiency of a certain enzyme, leading to accumulation of sulfides in various organs, including the CNS. And these sulfides will impair the process of myelination. And because the sulfides has his characteristic histologic staining, and hence the name of the disease. Although it is the most common hereditary leukodystrophy, the prevalence is 1 per billion newborns, and it affects the white matter bilateral symmetric. About the start of the disease, whether it's anterior, then progress to posterior, or the opposite, is not a prominent feature of this particular disease. But we have two other leukodystrophies where the start of the disease is very important, like adrenoleukodystrophy, which starts posteriorly, and Alexander disease, which starts anteriorly. One of the prominent features also is the spare of the subcortical U fibers. The subcortical U fibers are these areas where if you look carefully and you see a dark signal bordering the edge of the white matter. And this dark signal represents the normally myelinated white matter, while the bright signal represents the unmyelinated white matter. Most of the patients present by in the age of 1 to 2 years, and the appearance, of course, in an MRI is not that specific. You got some abnormal signal in the white matter, both in the frontal, parietal, and occipital lobes, and these white matter will show high signal in the T2 and the flare images. The CT appearance of this group of leukodystrophies is not usually characteristic, except in Krabbe disease, which is only diagnosed by CT, and the MR picture of Krabbe disease is usually misleading. But in the rest of leukodystrophies, you got abnormal hypodensity in the white matter distributed throughout both cerebral hemispheres. This hypodensity, if you inject contrast material, it will not enhance. And in MRI, you got diffuse white matter abnormal signal, and you got a prominent feature here, which is extreme hypointensity of the thalami. And this is an example of to realize that leukodystrophy does not enhance with contrast. This is the T2, and this is the T1 post contrast. Also, a prominent feature of metachromatic leukodystrophy is what is known as the tigeroid pattern. The tigeroid pattern means that there are striations of low signal intensity similar to the skin of the tiger in the white matter. And these striations in the white matter represent the myelinated white matter. The myelinated white matter will be black, while the unmyelinated white matter will be bright. Then you see striations, and this is considered one of the pathognomonic features. Then to sum up about the metachromatic leukodystrophy, this is the most common hereditary type. The age incidence is 1 to 2 years in most of the cases. The subcortical U fibers are spared. The disease progresses from anterior to posterior. The tigeroid pattern is almost one of the prominent features, but is not constant, of course, in every case. There is no enhancement, and the lesions may show restricted diffusion. Then Krabbe disease is, as I have mentioned, the only one which is diagnosed accurately by CT. We have two forms of the disease, the infantile and the adult. And there are two prominent features of this disease, which are the atrophic brain changes and the hyperdensity of the thalami. It is also the sequelae of enzyme deficiency leading to impaired myelination. The CT findings include a small atrophic brain, diffuse low signal, diffuse hypodensity in the periventricular white matter, hyperdense thalami, and the basal ganglia. If you inject contrast material, it will not enhance. Then if you look here and you see the characteristic findings of Krabbe disease, hyperdense thalami, and atrophic changes of the brain parenchyma. Another example, then you see the hyperdensity in the region of the thalamus and the atrophic changes in the brain parenchyma. On MRI, you will see the atrophic changes of the brain parenchyma, and you see the thalami as hypo intense areas at their anatomic location. Then similar to CT, if you inject contrast material, this will not enhance. So to sum up about the Krabbe disease, it's a very rare. All of them are very rare. The onset is below the age of 2 years. CT is more sensitive than MRI in this particular disease. Atrophic brain changes are prominent. Hyperdense thalami and basal ganglia on the CT scan, and no contrast enhancement in both CT and MRI. The third one is the adrenoleukodystrophy, which is an X-linked disease seen in males in the age between 3 and 10 years. Then this disease has a particular characteristic location in the posterior aspect of the brain, the parieto-occipital areas, where you got the unmyelinated white matter as hypodense areas around the trigone and occipital horns of the lateral ventricles. This white matter will show high signal in the T2 and the flare, and in the diffusion weighted images they will not show diffusion restriction. But if you inject contrast material, the margin of the lesion will show contrast enhancement and is known as the active leading edge or the inflammatory edge of the disease. This is the characteristic appearance of adrenoleukodystrophy by MRI: low signal in the T1, high signal in the T2 and the flare, and marginal post-contrast enhancement of the leading edge. Another example, CT can reach the diagnosis very easily in this adrenoleukodystrophy, and also MRI findings are very characteristic, especially whenever you see this enhancement of the edge of the disease. Another example, and you see a high signal in the T2, low signal in the T1, and faint marginal post-contrast enhancement of the leading edge, which suggests the presence of active inflammation. To sum up with adrenoleukodystrophy, this is an X-linked disease. The age is between 3 and 10, symmetric lesions in the bright occipital area, enhancement of the leading edge, and calcium may be sometimes seen. Now, the fourth one in this group is the Blasius-Merzbacher disease. This Blasius-Merzbacher disease is also rare and typically occurs in young boys, and there is, of course, arrest of myelin development. The resultant changes are almost similar to metachromatic leukodystrophy, including the tigroid appearance. And while the metachromatic leukodystrophy may show diffusion restriction, this disease will not show diffusion restriction. One of the characteristics of metachromatic leukodystrophy is the spare of the subcortical U fibers, but in this disease, the subcortical U fibers are not yet developed. Then if you look here, then you see the tigroid pattern, which is a prominent feature of metachromatic leukodystrophy and also a feature of Blasius-Merzbacher disease. The U fibers are not yet myelinated in this disease, and the changes will show diffusion free, while the metachromatic leukodystrophy will show restricted diffusion. Then if you look to this case, for example, and see abnormalities in the white matter, then whenever you are asked about the possibilities, you know that metachromatic leukodystrophy is on top of the list and is considered the commonest of them. And if you look carefully here, you can easily appreciate that the subcortical U fibers are spared. Then it's an easy diagnosis to say that this is a metachromatic leukodystrophy, especially if you identify the tigroid pattern in the white matter. But this disease has been proved to be a Blasius-Merzbacher disease. Actually, I am in my practice confronted by many of patients with leukodystrophies, and I don't remember that I have diagnosed for once the Blasius-Merzbacher disease, but I diagnosed many cases with metachromatic leukodystrophy. Then Blasius-Merzbacher disease is a rare neurodegenerative disorder, X-linked, typically seen in boys. It shows the tigroid pattern. It shows diffusion restriction. The next is known as Alexander disease, and this Alexander can be diagnosed easily by CT and by MRI. The etiology is unknown, and the prominent feature here is the involvement of the frontal lobes, much more evident compared to the posterior parts of the brain. Enhancement is also one of the prominent features of this disease. And you can see bilateral mainly frontal, and to a lesser extent occipital white matter abnormalities, and you can see the enhancement of the of the edge of the lesion, and sometimes you got enhancement of lesions in the brain stem, because this disease has an impact also on the brain stem. The literature says that you should have 4 or 5 criteria to diagnose Alexander disease. Number 1, extensive mainly frontal white matter changes, periventricular rim of bright signal in the T1. And the explanation of this rim is not clear. If you look carefully here, I think you can appreciate this high signal. Then brainstem abnormalities, abnormalities in the basal ganglia and the thalami, contrast enhancement of the affected white matter. This is an example of prominent brainstem affection in Alexander disease with significant post-contrast enhancement, as you can see. Then final words about Alexander disease is rare, typically presents in infants, affects mainly the frontal lobes, abnormal signal in the basal ganglia and thalami, contrast enhancement. The last one in this group is Canavan disease, and it has the 3 types of onset. It affects the white matter all through the brain parenchyma, and the same changes in the CT can also be appreciated on MRI. Is a rare disorder, selectively involves the subcortical U fibers. The subcortical U fibers are involved by this disease, and it may start in the occipital lobes, and the internal capsule is relatively spared. Internal capsule is not usually affected in this disease. Then Canavan disease is the result of an enzyme deficiency which affects the synthesis of N-acetyl aspartate. And the accumulation of N-acetyl aspartate in the brain parenchyma will result in what is known as vacuolated white matter. If you look carefully, you see many cystic changes in the white matter, which are similar to the Virchow-Robbins spaces, and the literature may consider them as dilated Virchow-Robbins spaces. We'll mention this in the second part of the talk. You remember from yesterday that Canavan disease is the only disease that elevates the peak of N-acetyl aspartate compared to other peaks on the MR spectrum. And this is one of the easiest ways to reach the diagnosis of Canavan disease. Whenever you see extensive white matter involvement, and you see the characteristic vacuolation of the white matter, and you go for MR spectroscopy and you see the peak of NAA is very high, then you reach the diagnosis of Canavan disease. Canavan disease is a rare lesion. It's common about the age of 4 months. It selectively involves the subcortical white matter. It starts posteriorly, then progress anteriorly. The internal capsule is not usually affected. Restricted diffusion may be seen. No post-contrast enhancement. MRS is very characteristic, showing a marked increase in the N-acetyl aspartate peak.